Okay, so good day. So for today, we will be discussing the serology and molecular diagnosis of HIV infections. So first, let us differentiate first. What's the difference between HIV and AIDS? So these two are entirely different, and it's very important that we'll be able to differentiate them. So HIV, as we all know, stands for human immunodeficiency virus. Okay? So HIV is an etiologic agent. Okay? And once the virus enters your body, you'll now have the HIV infection. However, AIDS is different. AIDS stands for acquired immunodeficiency syndrome. Usually, it is a syndrome. And when you say syndrome, it is a collection of signs and symptoms that are associated with debilitated immune system. And this is primarily attributed to a CD4 level of less than 200 times 10 to the 9 per liter. If this is your CD4 level, which by the way is your T helper cell, you become what? Immunocompromised. And if you are immunocompromised, you will be prone and susceptible to opportunistic infections, which we will be discussing later on. So if you have opportunistic infections that are attributed to a CD4 level of less than 200 times 10 to the 9 per liter, then that is considered to be as AIDS or acquired immunodeficiency syndrome. Okay? So the acquired immunodeficiency syndrome, so in the United States, they discovered it that in 1981, there was this cluster of young homosexual men who developed pneumocystis and Kaposi sarcoma. So pneumocystis and Kaposi sarcoma are not these two are rare, and these two are only associated with a depressed immune system. And true enough, the common denominator of these men is that they showed lost immune function. Until 1983, uh, the virus has been discovered. So actually, there was this one very nice movie, and the band played on, and it will show you the history on how HIV was discovered. Okay. So the origin of AIDS. Um, they say that they crossed the species barrier into humans in Africa in 1930s. Uh, Originally, the virus infects the rhesus monkey. Okay, we know for a fact that viruses are specific to the species. However, because of the fact that they were able to cross the species barrier, now they're able to infect humans. Okay, so the first reported cases was from Congo. So there was this patient who died in 1959. And because of the rapid and rampant urbanization, it spread now all over the world. In fact, we consider AIDS as a pandemic because it is seen in more than two WHO geographic regions. And that's how we define pandemic. So it spread in Africa, again as a result of urbanization, and worldwide through modern transportation and unsafe sexual practices. In 1976, the first known case in the Western world was actually a Norwegian seaman, so who traveled in different countries, and that's how probably he got the AIDS, HIV infection. So let's talk about HIV. HIV is an RNA virus. In fact, it belongs to the family Retroviridae. Retroviridae is a unique virus because of a specific enzyme known as reverse transcriptase. And it actually opposes the central dogma of molecular biology. Because if we will be reviewing the central dogma of molecular biology, okay, it is the DNA who dictates to RNA what protein is to be produced or to be synthesized. However, because of the presence of reverse transcriptase, RNA virus can actually synthesize complementary DNA. So when the RNA virus produces copy of the DNA, we call that particular copy of the DNA as the proviral DNA. So when they are starting to produce copies of DNA, then we call it a proviral DNA. So the 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 the, the virus is about 80 to 120 nanometer, okay, in size, and it is positively stranded and can integrate into the host chromosome as proviral DNA. So if the virus is able to integrate into host chromosome, then we call it as a provirus. Okay. The virus would only attack the T helper cells. Would only attack the T helper cells. And T helper cells, by the way, is one of the most important cells of our immune system because it is important in both cell-mediated immunity and humoral immune response. Okay? And the primary reason why it can only attack T helper cell is because of the presence of two receptor sites. Okay? So CCR5 and CXCR4. And then they also have the main receptor site, which is the CD4 receptor, and the co-receptor sites, which could either be CCR5 and CXCR4. Because of the presence of this receptor, then HIV is able to attack the T helper cell. And eventually, it will integrate, okay, the RNA into the host chromosomes. Then it becomes the proviral DNA. Okay, so that is basically the characteristic of the virus. So it's a retrovirus and it contains two copies of single-stranded RNA, as you can see here. And one of the most important enzymes that are present here is the reverse transcriptase. This is now the function of the reverse transcriptase. It will transcribe viral RNA into DNA. So we call it the proviral DNA. This one is being surrounded by a protein capsid. And the outer envelope is also being made up of glycoproteins embedded in lipid bilayer. So what are the different markers of the HIV? So we have um, the envelope proteins. These two are the envelope proteins. We have the docking glycoprotein and the transmembrane glycoprotein. This particular envelope glycoprotein is important for viral penetration, particularly when the virus will try to fuse itself into the cell membrane of the T helper cell. Okay, and then we also have the matrix protein, the P17, and then the capsid or the core protein, which is the P24. Remember, P24 is the earliest detectable marker. during the HIV infection. Okay, two important enzymes are written here. The integrase, which will, by the way, integrate the viral chromosomal nucleic acid, the viral nucleic acid into the host chromosomal DNA. So that's the function of the integrase. And of course, the reverse transcriptase, which will transcribe the viral RNA into the DNA. And of course, the viral RNA, which is the most important factor for the infectivity of the virus. Okay, so these are some of the most important markers for the HIV. And of course, the main marker that we are using to detect or determine viremia or viral load is the presence of the HIV RNA. Okay. So as you can see also, the HIV P24 antigen is the earliest detectable marker. So this one is HIV RNA. So this marker will actually determine the level of viruses in the blood or the viremia level, or simply known as the viral load. Now, if you will be sequencing the genome of HIV, these are some of the most important or noteworthy to mention genomes. So from 5 prime, this is the 5 prime to the 3 prime end, you can find several genomes such as the LTR, the long terminal repeats, the GAG, the POL, VIF, VPR, VPU, and NEF, and then at the end of the 3 prime end is the long terminal repeats again. So noteworthy to mention are these 3 genes. The GAG, okay, POL, and the N. Okay. The GAG genes will code for nucleocapsid and core proteins, particularly the precursor of protein 55, and this would include P16, P6, P9, P17, and P24. So these are the precursor. Okay, so the POL will code for viral enzymes. So this includes the reverse transcriptase, the integrase, the polymerase, which is important for replication, and also the following markers such as P66, P51, P31, and P10. And then the N will code for viral proteins. Okay, the GP160 precursor, which by the way is further subdivided into GP41 and GP120. By the way, when we talk about the precursor, we're going to sum up. We're going to sum up these particular proteins. This will actually be the totals, or that would be the summary of the name of the precursor. So for example, 41 plus 120 is 161. So that's why the name of the precursor is GP160. So that's approximately 160. Okay, and how do we um, how do we uh, how do we divide the precursor? It is also through another enzyme. So during the viral assembly. So during the viral assembly, these enzymes will be spliced. Okay, these enzymes will splice the main precursor proteins so that they are subdivided. Anyway, um, moving on. Let's specifically talk about the HIV genome. The GAG gene will synthesize for the core and capsid proteins of the virus. Okay, the POL, the polymerase, will synthesize the polymerase enzyme, the reverse transcriptase, and the nuclease and protease. By the way, it is the protease forget to mention a while ago in my previous slide, it is the protease enzyme that will subdivide the main precursor protein into several submarkers. Okay. And the one that is, of course, responsible for its synthesis is the pol. And then the end is the envelope gene, which will produce the spike glycoprotein, and its precursor is known as GP160. And then the TAX and REX are important for transactivation of the virus. The TAC gene, both of are also important for the upregulation of the HIV replication. So as you can see, the TAT and the REV, the VPU, they are important for us. They are classified here as the regulatory genes. Okay. Okay. So like for example, the REV regulate expression of the virus. ART and TRAs upregulate the presses the NEF. NEF, negative early factor, downregulates the viral expression. The VIF will help initiate the replication. Okay, so these are some of the genes that can be found in the genome of the HIV. So this photograph is the electron microscope of the virus attacking our CD4 or the T helper cell. So that's how they look like. So nakikita ninyo na small bluish-like structure here. These are the HIV. And this is now a CD4 or CD T helper cells that is lysed already. So these cells are already lysed. Okay, so a while ago, we're talking about CXCR4 and CCR5. So we call them as the chemokine co-receptors. And they are very important for the um, transmission and replication of the HIV because the virus will not be able to enter our T helper cell without the presence of these chemokine co-receptors. So these chemokine receptors, which we have already discussed when we were talking about cytokines, were members of the large family of the seven transmembrane domain G protein coupled receptors, and they are important in immune and inflammatory response. And as you can see, these particular co-receptors, chemokine receptors, will facilitate the entry of both HIV-1 and HIV-2 inside the T helper cell. So the CCR5 is a cofactor for the entry of the R5 tropic strains of HIV. So it is the receptor for the CC chemokine. So it's identified as Rantes, MIP1 alpha, beta, and MCP3. It is expressed in blood-derived dendritic cells, subsets of T helper 1 lymphocytes, and CD34 hematopoietic cells. Okay? So yung CD34 is our marker naman for stem cells. Okay? Together with CD4, it is important for the transmission of HIV and establishment of infection. Okay, so by the way, this particular picture here is the envelope glycoproteins. Okay, so the precursor is GP160, and there are two subunits, GP120 and GP41. So let's talk about the life cycle. The life cycle of the virus happens and divided into the following. So the first step is viral attachment. Then there would be viral penetration and fusion, uncoating, reverse transcription, nuclear entry, integration, and RNA transcription. Then there would be protein synthesis and protease cleavage, and then viral assembly and budding. So when we talk of budding, it means that the HIV will now leave the cell and will use the cell membrane of the host. So HIV will leave the cell and will use the cell membrane of the host to be used as what? Its envelope. Kaya pala yung mga envelope ng mga viruses, it's actually not virus encoded. Kinuha lang nila yan sa cell membrane ng mga host. Okay. So perhaps before we discuss the replication of HIV, let me show you first the GIF animation so that we'll be able to understand it much better. So yan. So the virus through the envelope glycoproteins and chemokine co-receptors, CCR5 to XCR4, will attach to the T helper cell. Then there will be conformational change in glycoprotein 120, and that will allow the entry, and then conformational change in glycoprotein 41, and that will allow the entry of capsid. Okay, particularly the core of the virus that contains the nucleic acids and the enzymes. So the envelope will be left behind. And then the core would be uncoated, and then it will release the single-stranded RNA. And remember, we have an enzyme known as reverse transcriptase. So the virus has the enzyme known as reverse transcriptase, and it will now start to encode DNA. So ssRNA to ssDNA real quick. And then from single-stranded DNA, it will now encode into double-stranded DNA. So it is now the provirus. The double-stranded DNA of the virus will integrate itself into the host DNA as it enters to the nuclear pore through the enzyme integrase. So the enzyme integrase inserts, and now you have the provirus, the proviral DNA. So the provirus will now control the genetic machinery of our T helper cell. They will now start to produce proteins that we don't need, but these proteins are needed to form new viruses. In other words, they have become our parasites and would utilize our genetic machinery so that they would be able to produce proteins. Now, these proteins will eventually be assembled. Okay, you now have the proteins. Yeah, proteins are now being encoded, and these proteins are long proteins, and they need to organize it. So this is where the protease enzyme will come in. So the protease enzyme will cut the long strands of amino acids so that it can be, so that viral assembly could be facilitated. Like for example, GP160 will be cut by protease so that it could become GP41 and GP41 and GP120. And so that's the function of the protease enzyme. So it will be assembled. No? So once the assembly has taken place, okay, the assembly means that you now have the proper, all of the components needed to form new viruses. Then the next step would be budding. In the process of budding, the virus will utilize our cell membrane as its envelope. And now the virus is not mature and will infect another T helper cell. Okay, so that's the life cycle of the virus. So you do not want this virus to enter your body. Because as you can see in the life cycle, it will control your T helper cell and it will destroy your T helper cell. Okay, so going back, so what are the steps? So attachment of HIV to host cell. So we call it the viral penetration, viral adhesion, and eventually there would be penetration. But for penetration, CD4 is required. Co-receptors such as CCR5 and CXCR4 are required. Okay, let me share my screen again. And so now that we've talked about the animation, the life cycle, so we can now easily understand the replication of HIV. So the first step is attachment of HIV to the host cell. So there would be what? Adhesion or attachment, as you can see here. And then the main target is the CD4. This is the CD4, but co-receptors. So this could either be CCR5 or CXCR4. Now in the illustration, we have here the CXCR4. Then there will be fusion and uncoating. In fusion and uncoating, take note, the main event that happens here is the conformational change of glycoprotein 120 and glycoprotein 41. And then there would be uncoating, meaning to say only the core will enter the host cell. And then the last here in the slide is the reverse transcriptase, which converts viral RNA into complementary DNA. What does it mean? So because of the reverse transcriptase, single-stranded RNA is converted into single-stranded DNA. And because of the presence of the polymerase enzyme, then it becomes now the double-stranded DNA. So this double-stranded DNA is what you call the proviral DNA. Okay, and then next is the replication. DNA is integrated into the host genome, and then they are now called the provirus. And this is made possible because of the enzyme integrase. Okay, it is the enzyme integrase that will allow the integration of the DNA into host genome as a provirus. So the viral DNA is transcribed into viral RNA and proteins. Proteins will now be produced and assembled. Here, the most important enzyme here would be the protease, so that long strands of proteins will be organized and assembled. And then intact virions will bud out of the host cell membrane. This process is necessary so that they would become enveloped. And this process is called budding. Ito na yun, guys, budding. Okay, so this is the life cycle of the HIV. Okay, so let's talk about the modes of HIV transmission. So basically, HIV is found in our body fluids. So they are found in our body fluids. So if we get or if there is an exchange of body fluids, that is a very effective way, efficacious way of transmitting the virus. And how can we get the body fluids of other people? Well, the, well, primarily you can get it through unprotected sexual contact. So intimate contact involves exchange of body fluid, and this one is responsible for majority of cases. Not to discriminate anyone, but the main the main type of sexual contact is usually via MSM, which stands for men having sex with men. Okay? So aside from that, there could also be contact with blood or other body fluids, such as the intravenous drug use, particularly if you're using unsterile syringe, recipient of transfusion and other blood products, and occupational injury. This one is very common for us medical technologists. That's why you really have to be careful because of the possibility of accidental needle stick or mucous membrane exposure. Perinatal is also possible, particularly the mother to child transmission before, during, or after birth, specifically through breast milk. Okay, so these are the modes of HIV transmission. That's why later on you will notice in statistics that uh, there are even cases of children having HIV. So take note that HIV survives 6 hours outside a cell. So HIV survives less than 1.5 days inside a cell. And infected body fluid will transmit HIV via the following. You can get it via sexual contact, breast milk, transplacental infection of fetus, blood contaminated needle, organ transplant, artificial insemination, and even through blood transfusion. So these are the different ways where we can get HIV. And do you know that it's common all over the world? So that's the reason why it is considered as a pandemic. Okay, in Western countries, even in Northern Africa, the most common is through male to male sexual contact and injecting drug use. In sub-Saharan Africa, heterosexual contact. But I think these particular slides have already changed, particularly in the Philippines, because I have the latest statistics. According to World Health Organization, okay, there are 37.7 million people living with HIV or AIDS worldwide. And this statistic was taken in 2020. So perhaps at this juncture, it has already increased. And 2 years ago, there were about 680,000 people died, okay, of HIV-related illnesses worldwide. Okay, so there are there were 90 low and middle income countries reported a total of 190 million people tested and received results in 2018. So it's very nice because active testing is very important for HIV. So if you will be looking at the global situation in trend, no, since the beginning of the epidemic, they haven't called it pandemic, but it's actually a pandemic. 79.3 million people have been infected with the HIV virus, and 36.3 million have already died of the HIV since 1983, perhaps, or 1981. Globally, 37.7 million people were living with HIV at the end of 2020. An estimated of 0.7% of adults aged 15 to 49 are now living with HIV. So that's the age bracket, no? 15 to 49 years. Although the burden of the epidemic continues to vary considerably between countries and regions. In African region remains the most severely affected, with nearly, take a look at it, 1 every 25 adults, or about 3.6%, okay, adults are living with HIV, accounting for more than two-thirds of the people living with HIV worldwide. So yon, sa Africa talaga, pinaka-common yung HIV. And if you will be looking at this very sad statistics, no, um, in 2020, out of the 37.7 million, 36 million is adult, while 1.7 million are children. Now, there are more women with HIV as compared to men, 16.7 million. Okay? How about in our country? In the Philippines, in January 2021 alone, 890 people got infected. Meaning to say, in a span of 1 month only, 1 month only, 29 HIV new cases are being reported, and majority of these are male, 152, and only 38 are female. And the main age group here, the main age group is actually uh, 15 to 34 years of age. Ito yung pinaka-common age bracket. Okay? So in the Philippines, majority of the cases are found in NCR, and only 20%. Oh, next is Region 4A, where our province belong, 20%. And then next is Region 3. And in the Philippines also, the most common is the male to male sex. Okay? Majority of cases is attributed to male sex. And this one, sex with male and females, it's a bisexual. So, and then followed by heterosexual intercourse. There are also cases of getting sharing of infected needles, and there's this one case of mother to child just in January 2021 alone. Okay, so HIV therefore is the cause of AIDS, or the acquired immunodeficiency syndrome. So there are two main clades of HIV, HIV-1 and HIV-2. So HIV-1 is the most common infections worldwide, the most common infections worldwide. And there were about four groups, the M, O, and P. M is actually the major group. And then there are 9 subtypes in group M, A, B, C, D, F, G, H, J, K. And then HIV-2 originated in West Africa and causes fewer cases. So like what I've told you, HIV-1 is the most common, and it has 11 clades. And HIV-2 is seen in Western Africa. How do our body respond to HIV? Well, our body responds in various ways. This is our natural immunity. Natural killer cells mediate cytolysis of HIV-infected cells. And dendritic cells will stimulate the release of cytokines that have antiviral effects. These are the specific immunity. Okay? And specific immunity will involve humoral antibody production and cell-mediated immunity. So when you say humoral antibody production, we are able to produce antibodies by 6 weeks after the infection. So antibodies produced later may prevent HIV from infecting host cells and participate in ADCC. But in cell-mediated immunity, T cells will produce cytokines with antiviral activity, and eventually the cytotoxic T lymphocytes will be able to destroy the HIV-infected host cells. But the question is, for how long? Okay. There would eventually be immune abnormalities resulting to HIV infections. For example, the CD4 will have a decreased proliferative response and decreased lymphokine production. For monocytes will also be affected. There would be decreased CD8 activity against target cells, decreased delayed hypersensitivity response, decreased chemotaxis, decreased interleukin 1 production, decreased microbicidal activity, decreased cytotoxic activity for natural killer cells, and for B cells, there would be decreased antigen-specific humoral response and uncontrolled production of antibodies. So imagine HIV will entirely affect our immune system. Then there will be a direct immune suppression. Okay. One is cytosidal effect on CD4. Remember, the main normal range of CD4 is between 800 to 1000 times 10 to the 9 per liter. So if it becomes below 200, then the condition would be AIDS. Then there would also be a functional defects on infected CD4 and impaired antigen presentation of monokine production by macrophage. Now, this would be the indirect effects. No, there would be generation of T suppressor cells or factor, inverse CD4 CD8 ratio. Let me tell you that the normal CD4 CD8 ratio is 2:1, but in cases of HIV, could become 0.5:1, and in worst case scenario, 0:1. So that's what we meant by the reverse CD4 CD8 ratio. There would be induction of autoimmune phenomena, cytotoxic cell activity against viral or soft proteins, and decreased humoral immune response. So how do you think the virus escaped our immune system? One important factor is the ability of the virus to have genetic mutations. They will constantly change, generating new viral mutants with altered antigens, causing confusion to our immune system. Not only that, HIV can also downregulate expression of the major histocompatibility complex 1 molecules on infected host cells. As we all know, if MHC1 expression is affected, then cytotoxic T lymphocytes will not be able to efficiently destroy the cytotoxic the CD4 that is infected. HIV can survive as a latent provirus for a long period. So there is a period of latency. When we say latency, they are inactive. They are just hiding. Okay? As a result, HIV persists and destroys the immune system. CD4 T cells are the prime targets of destruction. And as we all know, T helper cells or the CD4 is actually the most important cell of our immune system. It will affect both the efficacy of the cell-mediated immunity and the humoral antibody response. So these are the things that could happen, no? Infection of lymphocytes and macrophages, inactivation of CD4, which will incapacitate our immune system. Then there will be antigenic drift of glycoprotein 120. This results to mutation, heavy glycosylation of glycoprotein 120, and latency. So the clinical course of HIV infection is divided into 3. Okay, so we have the primary infection. This is the acute early infection. It may be asymptomatic, or you may have a flu-like syndrome that resolves. It is characterized by high level of viremia. So when we say high level of viremia, it means that there is a high viral load. Okay? Clinical latency is the absence of clinical symptoms, and eventually there would be a decrease in viremia and increase in CD4 T cell number. However, when we say AIDS, we are now in acquired immunodeficiency syndrome. So it is the resurgence of viremia and decrease the CD4 T cell number, particularly in less than 200 times 10 to the 9 per liter. So there is a profound immune response with appearance of life-threatening opportunistic infections and malignancies. So according to CDC, they have divided this into three categories: Category A, Category B, and Category C. So, so hello, hello, hello.
Hello po.
Hold up. I'm sorry for that. Somebody called me. Okay, so as you can see, CDC has divided it into Category A, Category B, and Category C. So Category C is already the AIDS. Our indicator here is you have less than 200 cells of CD4 times 10 to the 9 per liter. So Category A is characterized by asymptomatic or chronic lymphadenopathy. Category B is characterized by symptomatic or early indication of immune failure, while Category C is characterized by AIDS indicator conditions. Okay, so these are the three major categories, and Category C is already classified as the AIDS defining conditions. And usually, these particular categories are characterized by different our associated signs and symptoms and associated opportunistic infections. And according to CDC, category C may even last up to 10 years, particularly if the patient is not in antiretroviral therapy. And at first, um, in category A, you are off, you are symptom free, and then you have a less severe infection in category B, but you'll have a severe opportunistic infection in category C. But at the latter part of category B, this is where malignancy, AIDS-related dementia, and AIDS-related complex will start to occur. Okay, at the latter part of the category B, until such time that you will now develop severe immune deficiency with viremia in category C. Okay, so in the laboratory, you would be encountering patients with different test abnormality. For example, people with HIV would have, in hematology, they would have low hemoglobin level, low platelets, low WBC, the presence of atypical lymphocytes, increase in lymphocytes, or sometimes even absence of lymphocytes. So it's kind of extreme. Okay. Also, In immunology, my internet connection is lagging, so my apologies. Let me share again my screen. In immunology, there would be elevated immunoglobulins, IgG, IgA, and to a lesser extent, IgM. So there would be abnormal T cell subsets. And then there is also a cutaneous allergy on delayed type hypersensitivity skin testing, probably because the level of the TDH cells are also affected. In biochemistry, there would be elevated total protein with hypergamma globulinemia, abnormal level of liver enzymes. This is attributed to elevated um, alkaline phosphatase and transaminases such as SGPT and SGOT. And then there would be arterial hypoxemia with or without radiological abnormality. In anatomic pathology, the most common type of malignancy is Caposi Sarcoma. And this is also accompanied by lymphoma, follicular hyperplasia, histological evidence of opportunistic infection, and sometimes forensic examination in suicidal case are also seen. Is also can also be a possibility in some cases because of the depression brought about by having HIV or AIDS. So let me discuss to you what are the different opportunistic infections in AIDS. This can be divided into a protozoan infection. So Cryptosporidium hominis can cause diarrhea. Toxoplasma gondii can cause encephalitis. Isospora belli can cause gastroenteritis. Viruses can also become opportunistic. Cytomegalovirus, um, characterized by fever, encephalitis, and blindness. Herpes simplex virus is characterized by vesicles of skin and mucous membrane, and varicella zoster is characterized by shingles. Bacteria could also become opportunistic, such as Mycobacterium tuberculosis, obviously causes tuberculosis, and the MAIC complex or the Mycobacterium avium intracellular complex would infect many organs. And I haven't even mentioned here Mycobacterium ulcerans. Fungi, the most common opportunistic infection. The most common opportunistic infection is Pneumocystis jirovecii, which can cause life-threatening pneumonia. Histoplasma capsulatum can cause disseminated infection. Cryptococcus neoformans can cause disseminated infection and especially meningitis. Candida albicans could be, there are two types of Candida albicans infections. In category B, it is mucocutaneous. But in category C, it is systemic. Okay, systemic candidiasis. When you say systemic, there is an overgrowth in esophagus, lungs, and of course, there could also be cancers or precancerous state. These are Caposi Sarcoma. It is the cancerous skin and blood vessels caused by human herpes virus 8. Hairy leukoplakia, characterized by whitish patches on mucous membrane, commonly considered precancerous as well. And cervical dysplasia, it is the abnormal cervical growth. So as you can see, there are several, there are numerous diseases associated with AIDS. Okay, so it's called the ARC or the AIDS-related complex. So let me run through to you some of the illustration. Cryptosporidium parvum, which can cause diarrhea. Then here is a brain that is affected by Toxoplasma gondii. Isospora belli may cause diarrhea. Then this one is another. The colon here is affected with cytomegalovirus. Then this is a viral infection. Varicella zoster herpes simplex virus. Molluscum contagiosum is another viral infection. This one is shingles, a latent infection of chickenpox, but it could be opportunistic for HIV. This one is the atypical lesion caused by Mycobacterium ulcerans. Okay. Pneumocystis carinii or Girovechi could cause pneumonia. Okay. It's the most common pneumonia. Histoplasma capsulatum is another systemic mycosis. Cryptococcus neoformans, another opportunistic mycosis. Candida albicans, mucocutaneous candidiasis, and then Kaposi sarcoma sa precancerous state. So another example of precancerous state. Okay, the oral hairy leukoplakia is another precancerous state, and this one is keratoderma. Okay, another a malignancy caused by HIV. So as a medical technologist, it would be our responsibility to test our patients, and our testing can be divided into three. So screening and diagnosis, and before we have a previous algorithm. Before we were taught that Western blot, in previous algorithm, Western blot is the confirmatory test, but it is no longer the Western blot. It is now the fourth gen ELISA that is considered to be as the confirmatory test for HIV. It is not anymore the Western blot. For disease monitoring, we can do the CD4 T cell count, and this is possible by means of flow cytometry. And then the HIV viral load is possible through RT-PCR. And drug resistance testing is also a molecular diagnostic technique. Okay, and then testing of infants. So these are the consideration whenever we do diagnostic methods. So take note that seroconversion takes up to 3 months. So meaning to say, from the time of infection, there's a chance that you'll still be negative for 3 months. So HIV antibodies could be detected by screening techniques such as ELISA. HIV antigens could be detected by Western blot. Western blot is protein probe. And plasma viral load is determined by means of molecular techniques such as PCR or nucleic acid hybridization. So aside from those mentioned, it is also noteworthy to have P24 antigen, analysis of P24 antigen, because this one is considered to be as the earliest detectable marker. Culture, is it possible? Yes, but it's not practical and it's not routine. We can culture HIV using CD4 or the T helper cells, but it's not routine. CD4 CD8 ratio, this is possible through flow cell cytometry. Okay, for the previous algorithm, we have to screen first patients with ELISA or rapid enzyme immunoassay. So if the patient is positive, we confirm positive test result by repeating ELISA, and then we do the Western blot. So Western blot is protein probe. Okay, so here you detect antibodies against HIV markers. And to be considered as positive, you have to be positive in one of these, either of these, and either of these. So this one, therefore, is indeterminate because you are only positive with P55 and P24. But as what I told you have to be positive in either GP41 plus P24 plus either GP120 and GP160. Okay, so this is the previous testing algorithm. But now, so this is the actual result of the Western blot. But now, this is the current testing algorithm. Okay, so HIV-1 antigen-antibody combination immunoassay. So, if you are negative, then congratulations. You're negative for HIV-1 and HIV-2 antibodies and P24 antigen. So remember, it is not just an antibody testing, it's a combination of antigen and antibody testing. So if you're positive, it is now important to differentiate what kind of HIV has infected the patient. Okay, so if positive with HIV-1 and negative with HIV-2, meaning to say HIV-1 antibodies are detected. Positive for HIV-2 but negative for HIV-1, meaning to say HIV-2 antibodies are detected. But if positive for both, HIV antibodies are detected. Both antibodies are detected. Okay, but if you are positive here, but you happen to be negative here, you have an indeterminate result in HIV-1 and HIV-2, you are negative, there is about time that we do the nucleic acid hybridization technique. So if it's positive, then you are positive for HIV-1 infection. If it's negative, then you are indeed negative. This is now the acceptable testing algorithm as proposed by the World Health Organization. So how do we confirm for the presence of HIV antibodies? We are now using the fourth generation ELISA, which could detect HIV-1 antibody, HIV-2 antibody, and P24 antigen combination immunoassay. This one, okay? The combination immunoassay. This is now the current testing algorithm. So what is the specimen? The specimen is a patient serum. So we incubate patient serum with solid phase. And in the solid phase, it contains two types of antigen, HIV-1 antigen and HIV-2 antigen. And it also contains antibody against HIV-1 P24. Okay. Following incubation, HIV-1 or HIV-2 antibodies in the patient sample will bind to the respective antigen if the patient is positive. So HIV P24 antigen in the patient sample will bind into anti-P24 solid phase. So remember, this is a combination immunoassay. Okay? This is a combination immunoassay. So when we say combination, first we are detecting antibodies in the patient sample. Second, we are also detecting antigen on the patient sample. So it's a combination. So we wash, then add conjugate consisting of labeled anti-P24 and labeled HIV-1 and 2 antigens. Okay, so following an incubation, wash, and addition of trigger solution or sulfate subsolution, if the person or if the patient is positive, relative light units or optical absorbance are measured. Then we confirm positive result with rapid EIA. Okay, so rapid enzyme immunoassay. So the algorithm has already changed. Meaning to say, we perform first, this is step number 1, we perform first HIV-2 antigen antibody combination assay. So when you say combination assay, you are detecting both antigen and antibody coming from the patient sample. And then the step number 2 is that we should do the differentiation immunoassay because you want to differentiate whether it is due to HIV-1 or HIV-2. Okay? And then step number 3 is only optional for indeterminate result in order to have this particular interpretation. Okay, so this is now the current testing algorithm. So during the board exam, never answer Western blot. It is no longer a confirmatory test for HIV. Okay, so this is monitoring. So we can do the peripheral blood CD4 count, quantitative viral load, and drug resistant testing. So how do we do the T-cell enumeration? Why is it important? Well, this will determine viremia or viral load. So this will determine viremia or viral load. So these counts are the best indicator of immune function in HIV infected individuals. Doctors wouldn't want to see less than 200 cells. So we incubate peripheral blood with fluorescent labeled anti-CD4 and it is being analyzed by flow cytometry. If the patient is untreated, the CD4 will decline and the CD4 CD8 ratio is less than 1.1. We call it the reverse CD4 CD8 ratio. Okay. So CD4 of less than 200 indicates category C or stage 3 and this is now known as AIDS. So a significant decline in CD4 count over time may indicate a need to change the CART or administered prophylactic therapy for certain infections. Kasi nga, you need to treat also opportunistic infections. For example, merong fungal, then you need to treat the fungal infections. And then the quantitative viral load assay. Sorry, let me correct myself. This one is not for viremia. This one is for the viremia. Yeah, this one is for the viremia. I stand corrected and so apologize for that. Or viral load. The quantitative viral load assay. It measures the amount of HIV RNA circulating in patient's plasma. So it is the method is through qPCR and branch DNA amplification. So do you know that HIV RNA is detectable about 11 days after the infection? So if you want early detection, then this is the one that we should be doing, not the antibody testing, because it will take time. As what I told you, seroconversion will take about 3 months. So quantitative viral load will assess whether there has been successful therapy in CART results because kapag successful yung antiretroviral therapy mo, then the viral load will drop into undetectable level. However, if the ART is not successful, then there would be a significant increase in viral load. Therefore, there could be a drug resistance. So the next thing that we should be doing is to perform drug resistance testing and a possible change in CART. So this is the expected number of CD4 and plasma cells. As you can see in primary infection, the number of CD4 is at this level. However, it will significantly drop and eventually it will drop progressively. Okay? The viremia level is very high at first, but it will significantly drop during clinical latency and eventually when the CD4 level is now less than 200, the viral mRNA will now increase. And eventually, after 10 years without therapy, this could lead to the death of the patient. Okay. How do we prevent HIV transmission? Well, this is very important, no? Prevention. We should screen blood or organ donors for HIV, education of general public on HIV transmission, safety measures, precautions for healthcare workers, and vaccine. However, vaccine is being researched. It's quite difficult to develop vaccines for HIV. Why? Because the number one reason is mutations. And then there are several claims. The antibody binding sites are hidden. The infected cells are not susceptible to cytotoxic T lymphocytes. The presence of proviruses, it's the viral DNA plus our host DNA, and the latent viruses, these viruses that are hiding inside our host cells. So these are the reasons why it's quite difficult to develop vaccines for HIV. So to prevent, we should, of course, the best way to prevent is ABC. A is for abstain. Abstinence, be faithful, just have one monogamous partner, and just have sexual intercourse with your married spouse. Okay, so that is the best way to prevent HIV. Do not be engaged in sexual intercourse while you are not yet married. Okay, letter B, if you cannot do letter A, at least be safe. Okay, so how do we be safe? Okay, we can actually use condoms. Be faithful, sabi rito, and then be safe by using condom and using sterile needles. Sterile needles, no? If for IV drug users, but mas maganda, wag nang mag-drug, wag nang mag-addict, no? And then for us healthcare workers, complete PPEs are important. Then do not recap needles. Okay, the risk of infection from infected needle stick injury is about 0.3%. And we as medical technologies are at risk of getting it. Okay, so let's talk about the antiretroviral therapy. So the most effective is when you combine these drugs. So when you combine these drugs, we call it the CART, the combination antiretroviral therapy. As you can see, each of these cocktails, we call it the cocktails, will prevent each of the life cycle of the virus. Reverse non-analog, reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors. Obviously, this will prevent the formation of proviral DNA. Protease inhibitors will prevent viral assembly. Integrase inhibitor will prevent the integration of the proviral DNA into the host DNA. And then fusion inhibitors will prevent adhesion of the virus. It will prevent, and then entry inhibitors will prevent viral penetration. So these drugs will address each of the stage in the life cycle. So they have significantly improved morbidity and mortality of HIV infected persons and have reduced the rate of perinatal transmission. Now, for those people who are actively engaged in sex and drug users, injection drug users, the CDC or the Center for Disease Control and even the World Health Organization have introduced PrEP. What is PrEP? PrEP is a pre-exposure prophylaxis. It is a medicine people at risk for HIV take to prevent getting HIV from sex or injection drug use. So there are two commercially available. Truvada is for all people at risk through sex or injection drug use. And Descovy is for people at risk through sex, except for people assigned female at birth who are at risk of getting HIV from vaginal sex. Okay, assigned female. Ibig sabihin, totoong female or biological na female talaga siya. So, PrEP is safe, but some people experience side effects like diarrhea, nausea, headache, fatigue, and stomach pain. So, these side effects usually go away over time. So, wag lang natin gawing license yung PrEP to be promiscuous for sexual intercourse. PrEP reduce the risk of getting HIV from sex by about 99% when taken as prescribed. So, although there is less information about how effective PrEP is among people who inject drug use, we do not know that PrEP reduces the risk of getting HIV by at least 74% when taken as prescribed. So, PrEP is much less effective when it is not taken as prescribed. So, again, sino yung magamit ng PrEP? Sila yung mga, for example, sex workers, or sila yung mga tao na engaged talaga, very active in sex. So, PrEP reaches maximum protection from HIV for receptive anal sex or yung tinatawag ng botoning. Sila yung nagpapapenetrate ng penis sa anus for about 7 days of daily use. So, pag ano pala, you cannot have anal sex kung ikaw yung receptive partner. You cannot have anal sex for 7 consecutive days even if you are in PrEP. No, sorry. You are protected for only 7 days. Okay, during anal sex if you are in PrEP. But for receptive vaginal sex, or ito yung mga female, yung totoong female, and injection drug use, the maximum protection is about 21 days. So beyond 21 days, you are no longer protected. For for homosex or MSM, kapag kayo yung nag-receive ng kapag yung isang tao yung nag-receive ng penis sa anus, so we call it receptive partner. So that person is only protected for 7 days. Okay, beyond that, protection is no longer guaranteed. But then again, let's do not use PrEP as a license to become promiscuous. So, yun nga, the one that I've told you is yung highly active antiretroviral therapy. It's when you combine them. Yung mga nucleoside inhibitor, protease inhibitor. Okay, for those people, despite of the fact that they are in CART, yet the viral load is still very high, then maybe meron na tayong drug resistance in antiretroviral therapy. Then we can do now the drug resistance testing. For drug resistance testing, we perform it in clinical laboratory setting, and HIV reverse transcriptase and protease genes from patients in RNA plasma, in patient plasma, is amplified through RT-PCR. So the products would be sequenced and analyzed with software permutations. So that we'll be able to find kung meron bang resistance, possible resistance, or no evidence of resistance at all. Okay? So yung phenotype resistance naman, tandaan niyo yung genotype resistance, molecular yan. Pero kapag phenotype resistance, this will determine the ability of HIV from clinical samples to grow in the presence of antiretroviral drugs. So it will involve sophisticated technologies and will only be performed in specialized reference laboratories. So, testing of infants younger than 18 months. Ito, medyo kawawa sila kasi pinanganak sila sa parents na merong HIV. So, maternal antibodies in infant serum can complicate serologic test results. Kasi nga, newly born infants are not yet capable of producing their own antibodies. Therefore, molecular methods are used for diagnosis. Hindi tayo gumagamit ng serologic testing sa mga neonates. Qualitative HIV-1 DNA PCR using infants' peripheral blood mononuclear cells is the preferred method. So, molecular testing. We only do serologic testing at 12 to 18 months of age to confirm the diagnosis. Okay, so that ends our discussion for HIV infection.